Stuff happens. All right, we're talking about abdominal and GU trauma this morning. So here's what we're going to talk about. Basically all the things that go wrong in the belly. There's so many structures in there, it's very difficult to evaluate, especially with trauma patients. So it takes a high index of suspicion, and a lot of what we do is based on the mechanism of injury, which we'll talk about. But before we get into the meat and potatoes, it's important to look at the anatomy here. So it's important that we separate these in the anterior abdomen and then the retroperitoneum. So the importance is there's different structures in there, and they're separated by tissue. And so we can get different injuries in there, or different injury patterns, and sometimes those patterns may not manifest initially, especially when it involves the retroperitoneum. So the important ones that are hard to, that take a high index of suspicion are like the duodenum and the pancreas, which we'll cover later in the lecture and what sort of injuries we can have there. But one of the other issues, obviously the kidneys are commonly injured as well. Luckily with IV contrast, that's where it's pushed through, so it does light up. So it is a little bit easier to see the injuries there, but the duodenum and pancreas especially are important to pay attention to because they can commonly be injured, and we don't see on the CT scan, or there might be subtle findings on there that we have to watch out for. And then one of the other issues, especially with patients with distracting injuries, a lot of times like hemoperitoneum might not manifest with clinical signs of peritonitis that we might normally see, or peritoneal irritation. That's why it takes a high index of suspicion for these. And then we have to think about what structures lie where. Obviously you've got, like if you're wearing a seat belt, that's going right over a lot of your intestines, so we can run into a lot of complications there, which we'll talk about shortly. All right, so it's important we separate into blunt versus penetrating. So blunt, most of them aren't going to go to the operating room. A very low percentage will, I should say. So our evaluation for these typically is based, obviously, on our mechanism, history, physical, but we also like to get, we're also very liberal with how we're ordering our CT scans. So most of them are going to get further imaging if they're stable. So typically that starts with our x-ray and then our fast exam, followed by our CT. And then for penetrating, most of them are going to require surgery, especially if we think that it violated the peritoneum. And we're going to talk about some methods that we use if those very few patients that may not require surgery, what sort of procedures we can do for them. And then we'll talk about our couple different procedures. So we have like laparoscopy versus laparotomy. So one of them is cutting the belly open, one of them is using cameras. So it's important we differentiate those two, especially when you have answer choices. And then which ones do you guys think require surgeries like more often? Stab wounds or gunshot wounds? Yeah, gunshot wounds. Any gunshot wound in the belly is typically going to require surgery, other than the very rare circumstance, which we'll talk about here. All right, so what are the different procedures we can do? So we can do a diagnostic laparoscopy. So this is going to be done in a stable patient, and this is if we have like a tangential gunshot wound that we don't think has violated the peritoneum. We're going to look at possibly doing a laparoscopy, which is the top picture there where they're using scopes. And we're not having to open up the entire belly for an exploratory laparotomy. So these have to be stable patients. Typically it's with some sort of penetrating injury, and then we can establish whether that missile or whatever that object was that penetrated the abdomen, and then basically we're looking at whether it violated the peritoneum. If it did, then a lot of times we're converting to an exploratory laparotomy. But the other procedure the most common one we do is an exploratory laparotomy. So most penetrating injuries are going to get this, especially if anybody has shock. And then we might do it for blunt trauma if they're showing signs of like peritonitis. If we suspect any sort of hemorrhage inside the belly, that's going to be important to differentiate, and we'll do an exploratory laparotomy. And then like it says on the bottom, that blunt trauma is very difficult because peritonitis is uncommon in those injuries, but we can still have a rupture of one of those hollow organs. So that's why it's important we have a high index of suspicion for these patients. which is most of the time why we're getting CT. But we'll talk about when CT is not not as accurate for certain diagnoses that we have on here. And does everybody understand the difference? One, we're cutting the belly open. Have you guys ever seen one of those scars before? Basically goes, from the sternum almost to the pelvis, and they open them up. You see very large scars on patients who've had this done on them before. It's a very common procedure that we do in the operating room. All right, so our history is obviously one of the most important things we have to do for these patients. So, was this blunt trauma? Did they get a motor vehicle accident? Did they fall? Did they have, even for ground level falls, we can have injuries? Was it penetrating? Did they get shot, stabbed? And then how long ago did this happen? Because that's important. If it just happened 20 minutes ago, they might not be manifesting signs of shock yet. But if it happened 4 hours ago, which I know sounds, might not sound as common for those who haven't worked in a trauma room, but patients will present many hours, sometimes a day after their injuries, and they can still have pretty significant injuries that haven't manifested yet or are starting to manifest, which is why they came in 4 hours later, 6 hours later. Because, for me it's hard to believe because everybody shows up at the ER and we're like, whatever, there's nothing wrong with you. Some people are tough and they wait it out. So it is, we do sometimes have to look at when this happened, how long ago, and then we get a missed report from our EMS. That's if we can get our any medications they have, any allergies, important ones, or are they on any blood thinners or anything that's going to increase their bleeding risk is what we need to know. And then our missed report, does everybody remember what that is? Mechanism, injuries, symptoms, signs, and then treatment. So typically they're going to hopefully give us a set of vitals, obviously the mechanism, what injuries they have, and then what they've done so far en route. And like we've done during the trauma lab, it was similar to that. If the patient's stable, we'll typically get the missed report immediately before we transfer them over to the bed. Every facility is different. If they're unstable, then we're going to stabilize them first and then get a missed report from EMS. And I know in Texas that's a standard, they use missed report. Other states may not, so don't quote me on it. They might have a different type of EMS report. And they kind of differentiate those, which probably isn't important, but we have a South Texas Regional Advisory Committee that coordinates with the state, and we all kind of come up with the same guidelines that we use, so everything is standardized. And then after our history, we move to our primary and secondary survey, which we've talked about, and the procedures we do, and then the tertiary survey. Sometimes will be done if the patient's stable and we don't have any surgical injuries. We'll do a tertiary survey, treat everything. Sometimes it'll happen after the operating room, like I talked about. Things we didn't. If we weren't able to get to a secondary survey, we might have to do that later after that patient is out of the operating room, which we call a tertiary survey. All right, so it's important that we do a good abdominal exam on these patients. However, the presence of bowel sounds doesn't rule out the injury, and then if you don't have bowel sounds, it doesn't rule in an injury. So it can be kind of difficult to evaluate these patients. And then the other issue is they're going to have pain everywhere or distracting injury. So it can make our examination very difficult when we're performing that physical. And then ileus can be caused by anything. We cause it iatrogenically most commonly after surgery, but it can be, you can get an ileus from peritonitis or any of those other conditions on there. Really anything can cause it that kind of disrupts that inflammatory neurohumoral response that we have. All right, so percussion is helpful in the abdomen. I know, I don't want to taint you guys or anything, but a lot of times we may or may not be percussing lungs or other areas, but the one important area that, at least myself, I percuss on every patient is the abdomen, especially when they're coming in for any sort of belly pain or trauma that I suspect in that area. So dullness could be a sign of some sort of intraperitoneal bleeding, most commonly the liver and spleen. And then hypertympany can be signs of air. So if you have some sort of pneumoperitoneum going on, you might have some increase in air in that belly when you're doing that percussion. And then, like I said, they normally hurt all over. So some of those signs can be very difficult. Important ones we need to pay attention to, in particular, I mean, Great Turner and colon are a significant finding, and it usually indicates that they have, you know, some sort of intraperitoneal bleed. However, it's rare, it's not as common. So the most important one for us is a seatbelt sign. So with the amount of trauma it typically takes, or force it takes to create, you know, that ecchymosis we see on the belly, where the seatbelt is, it kind of clues us in to that they had a higher mechanism of injury, and we need to do a better job, or we need to have a higher suspicion for some sort of intra-abdominal injury. So, and like it says on in the notes there, like, you know, 30% of patients with a seatbelt sign can have some sort of internal abdominal injury. So that's, you know, in medicine we talk, I know we throw percentages all day, you guys, 25%, 50%, whatever, you know, all these random percentages. Most of them don't matter. What matters is when you look at those certain percentages and as they increase, like, okay, I need to remember that this might have a higher likelihood of an injury with this or that. And that's kind of how we differentiate these different pathologies when we're doing our history and our mechanism and, you know, whatever trauma that this patient sustained. All right, so what do we do for labs for these people? So we get a CBC, which everybody understand what we're looking at for these. It's not, I mean, we, you know, leukocytosis might help, but really what we're worried about is some sort of bleeding, so we're looking at their hemoglobin and hematocrit. However, sometimes their hemoglobin and hematocrit may not show a change yet in an acute injury, so if they present shortly after, which a lot of the, you know, significant mechanisms will present relatively within the first hour, hopefully. We have a lot better chance of survival if they do. That hemoglobin may not be manifesting yet or decreasing and showing that bleeding in the belly. So it's important we always remember that. It's not the end all be all. Okay, their hemoglobin is normal. Like I had a patient with, she had, I don't know, she said she was vaginal bleed, like profuse vaginal bleed. But her hemoglobin was normal, and she said it's been going on for days. But we still monitored her, rechecked the hemoglobin a few hours later, just to make sure that we weren't missing anything on that patient. So it may be normal initially. Then we get our CMP. So we always want to look at our electrolytes, and any sort of electrolyte derangement we need to evaluate, or we need to consider with whatever concomitant injury they might have. And then obviously, looking at our other factors in there, like their liver enzymes, can be a sign that there, you know, maybe some sort of liver injury or damage that we're overlooking. So it's important we evaluate those, and then obviously kidney function as well. UA, we want to look for any blood in there, and we want to get an HCG on all females of childbearing age. And we like to do a type and screen, just in case we're going to be giving blood. We want to make sure we know their blood type, and we start cross-matching blood. And then we have our other, some of our other, like our pancreatic enzymes, amylase, lipase can be helpful, especially for those retroperitoneal injuries. They, you know, if it's normal, it doesn't rule it out. If it's elevated, it doesn't rule it in, but it's one of those things that helps raise our index of suspicion that they may have one of those injuries. And then we get ABG or a BBG on almost all trauma patients that come in. And then we typically will get a blood alcohol level and urine tox on everybody, regardless, but that's also a consideration, and some facilities don't do it on everyone. So if you have a suspicion like that patient has altered mental status, and you don't think it's associated with their injuries, they don't have any evidence of a head injury, they don't have any like significant electrolyte derangements or hypoglycemic, then we might want to think maybe they're drunk, or maybe they're intoxicated, or some sort of toxidrome on top of this. And then here's our most common imaging. We don't really do an abdominal x-ray, but typically a chest x-ray and a pelvic x-ray. The chest x-ray is obviously one of our adjuncts to our primary survey, but it can tell us a ton, especially anything going on in the thorax, because that can be fixed without going to the operating room the majority of the time. So we're looking for any sort of, you know, pneumothorax, rib fractures, pulmonary contusions. And then we can do a pelvic x-ray. Typically when we roll the patient, we're getting that chest x-ray, and then we may throw a pelvic x-ray on there depending on if we see any signs of pelvic trauma, or if we have any sort of crepitus or abnormal findings during our when we're compressing the pelvis during that initial primary survey. So CT is going to be our probably, in all stable patients, we're usually going to get a CT on them typically with IV contrast. However, like I was saying, they can miss these hollow viscous injuries. So when we're talking about the pancreas and the duodenum, sometimes we may just see, if we're lucky, we'll see some air in there, maybe some free fluid, but all we might see is fat stranding. Those can be subtle indicators that something is wrong with that patient. So it's important that we have a high index of suspicion, because you have to think about, let's say it's less common now, but when they only wore lap belts, and so a lot of patients will still only wear a lap belt. So just think about they're going 70 miles an hour and they come to a complete stop with whatever they ran into. All of those organs are getting compressed against the spine, so we have to consider what sort of injuries they might have. So if that's the case, those are patients we need to have a higher index of suspicion, like they were only wearing a lap belt. Which, once again, I didn't say in our history, but it's important for most trauma patients when they come in, especially for motor vehicle crashes. What we want to know is where they were located in the car, whether they were restrained, what was their GCS on scene, and a lot of times, like where they, a lot of patients will be walking on scene and things like that. So those are all helpful. Those all help in our history when we're evaluating these patients. And that's something EMS will commonly tell you. They were walking around their car at the scene. Their GCS was 15, they were restrained, they were the driver, they were whatever, and then you want to know whether they were T-bone, whether they hit somebody head on, what type of collision it was, just look at their mechanism. For some of these injuries that we're worried about, these hollow viscous injuries, so these are patients, if we have a higher index of suspicion, we may want to add oral contrast for our IV imaging studies. This would be one of the times where we would add that when we're evaluating them. Typically we don't get oral contrast CTs, only certain conditions really require them. The most common we see are like, anybody who had a gastric bypass, we have to do a special oral procedure for them when we're evaluating those complications. Like it says on here, any delays in the diagnosis causes greater morbidity and mortality. But the important thing, and we talked about it I think last block, evaluating that C loop of the duodenum, is why we need that enteric contrast for these patients. All right. So for blunt trauma, most aren't going to the operating room. But as you can see, like that patient there has a pretty significant seatbelt sign, and then that's that scar I was talking about for the exploratory laparotomy that you're going to see in this. Looks like a blunt trauma patient on there. So our physical exam is important on these ones, especially more objective findings on that, like their obviously pulse rate, are they tachycardic, tachypneic, do they look like they're in any shock, what's their blood pressure. Then we have to consider any sort of other injuries they might have that could be distracting them from this. So like a lot of times long bone fractures are common with motor vehicle collisions. So we need to think about that when we're evaluating them. Because obviously we're going to be, if they have an open femur fracture, that's going to take a lot of our resources, and that's what's going to confuse us as we're evaluating, because that's a very significant injury that can cause a lot of bleeding, and we may miss that they have, some abdominal trauma that we're overlooking. So it can make our exam very difficult on these blunt trauma patients. And then, like I said, any seatbelt sign, it increases their relative risk. It's more than doubled that they have some sort of intra-abdominal injury. And then if we have any suspicion for a hollow viscous injury, or they have one, we also need to consider like our chance fracture, or those flexion distraction injuries of the spine. Just like I was saying, the amount of force it takes if you're wearing that seatbelt compresses everything. You have to worry about spinal injury as well, so that's something we need to think about if we have a patient that with the right mechanism and we have a hollow viscous injury, or if we have a chance fracture, we need to think about a hollow viscous injury and vice versa. So that's something always important to consider when we're evaluating these patients. All right, and like I talked about, there can be a latent period in, from when they present the expected signs and symptoms we think they should have from when they actually manifest those. So some of the elevations we might see are like that, like I said, a leukocytosis can help point us toward a hollow viscus injury, but this may not manifest if they show up 30 minutes after the injury. So that's why it's important we're doing serial evaluations on these patients if we suspect these injuries. And that amylase is a helpful test as well, which typically when we think about the pancreas and pancreatitis, lipase is a lot more specific for that, but an amylase can be helpful if it's elevated and they have hyperamylasemia. And their lactic acid as well, which is very non-specific, but it is an indicator that can tell us something else is going on that we're not seeing. And yeah, with low-risk mechanism, unlikely that they have a hollow viscous injury. It takes a lot of force to cause one of those. All right, so obviously our first step is going to be our ultrasound or our FAST exam when we're looking at imaging for these patients, followed by our chest x-ray. Any positive FAST and hemodynamic instability in the patient, they typically go right to the OR. Now where it gets a little more complicated is when we have a stable patient with a positive FAST, where's that bleeding coming from? Do we need to do something about this now, or do we have time for imaging? Because obviously the FAST doesn't tell us where the bleeding is, it just tells us there is some bleeding in there, and it doesn't also tell us how much is in there. So it's a helpful tool, but it's not the end-all be-all, especially when we have to make a decision in a stable patient. Can they go to the CT scanner, or should they go to the OR? All right. So we got patient MVC. This one's an obvious distress. So how do his or her vitals look? Not good, right? 140. That's like, probably up there with like class 3 or 4 shock. Diminished neck vein, jugular venous pulse is diminished, neck veins are collapsed, so obviously we're bleeding from somewhere, right? Then he's semi-conscious, pupils are reactive, he can localize with GCS, isn't at the point where we need to intubate yet. Then you got distension of the abdomen, all over with guardian rigidity. What's the most appropriate next step for this patient? Gonna be what? Yeah, XLAP, right? This patient is unstable. Now, what if we put FAST exam in there? Yeah, probably the FAST exam would be probably the correct answer. We try not to do those things, but sometimes stuff sneaks on tests. Don't know how, but they do. All right. So penetrating trauma. So most of these are going to, penetrating trauma in the belly, most of these are going to need some sort of operation or exploratory laparotomy. The exception is when we have that tangential wound. So this would be a stable patient who has an anterior, scroll there, who has an anterior gunshot wound, and they're stable, and we don't think it's violated the peritoneum. So these are patients that can either go for like a diagnostic laparoscopy. If they're stable, we're certainly going to get a CT scan on them. But this one we'll typically do the diagnostic laparoscopy on, and if we see any violation of the peritoneum, then we'll convert to an exploratory laparotomy and figure out where that gunshot or whatever that missile was that traversed the cavity, so we can further evaluate. And we'll talk about stab wounds in a second, and some of the things we do for those. All right, so yeah, lower incidence of abdominal injury than compared to gunshot wounds. If they're stable, then we can, selectively manage them, typically with further imaging, CT scans, obviously all our labs, which we're going to get anyway. But if we see like an evisceration or bowel sticking out, they're obviously going for an XLAP or we see omentum. And currently, we typically don't force those organs back in. We usually cover with a clean, wet dressing. You may see different protocols, especially for like, in the tactical setting where that used to be taught, where you place, if you're expecting long evac times and you don't have a facility to treat them at, they were placing those back into the abdomen and then throwing like a 1-0 stitch in there until they could get to the hospital to perform laparotomy. But that's not something we typically do in the civilian sector. So for those of you who are trained to do that, not something we typically do on the civilian side of the house. But anybody with penetrating injury or wound, we're going to get an exploratory laparotomy that we think violated the peritoneum. All right, so sometimes when it's unclear, so you see just a small knife penetrating wound to the abdomen, the patient is stable, we don't see any sort of bowel or omentum. Sometimes what we'll do is we'll do an exploration of that injury. So we'll tend to open that wound up a little bit more all the way down to the anterior fascia, and we evaluate in the emergency department or trauma room whether they had any violation of that area, so or fascial penetration. If they didn't have any, then no further treatment is necessary. We just have to clean that wound out and close it back up really well. For these procedures, we do typically sedate them prior to any of this. We do local anesthesia for them of the wound and give them, lidocaine, Marcaine. And then we like to decompress the belly as well and insert an NG or OG tube just to avoid the aspiration. And as you can see in the picture there, we typically don't like to do NPAs or NG tubes if we suspect any sort of facial injuries or fractures, just because we worry about sticking an NG tube in the brain like they did on there, which is poor form. Alright, so here's one of our nice complicated algorithms here, but it's all, it seems simple to me. I'm sure it's not simple to you guys, but typically, obviously, if they're stable, great. We have time to manage them and do further evaluation. If they're unstable, then they're obviously going to the operating room. So anybody that, we don't suspect a hemorrhage or hollow viscous injury and blunt trauma, which is most blunt trauma patients, we can typically do further imaging with our CT scanning and admit those patients for serial abdominal exams and repeat imaging. If we have confirmed hemorrhage, unstable, they go to the OR. If they're stable, then we can usually get some sort of confirmatory imaging on where that bleeding's coming from. And we'll talk about it in the next slides, but even for like liver injuries, even some of the higher grade liver lacerations that we see, we tend to manage them non-operatively. Or we manage them with interventional radiology and some sort of angiography and embolism, so that we don't have to open that patient up or remove a piece of that liver. And then for most penetrating injuries, they are going to the OR, especially if they're in shock, minus that tangential wound that I talked about prior. And then obviously when we look back at our anatomy, we can think about what's going to be injured most commonly. So the small bowel takes up a very large portion of that anterior abdomen. So that's typically the most commonly injured, those penetrating wounds followed by the large intestine and liver. The spleen is a little less because it has some protection there from those ribs. All right. So when considering blunt injuries of the abdomen, which one of these is the best expectation management counseling to provide the patient? Bravo. How come it's always the same people? All right. Why isn't it A? Yeah, because blunt injuries can do that. What about C? If we're talking about the belly, typically not. They're typically, plus you have your rib cage protecting that diaphragm, so it doesn't cause more diaphragmatic injuries. And then obviously we talked about blunt abdominal injuries can result in rupture of hollow viscous organs. It's just not as common. All right, so the most common solid organ and blunt trauma that's injured are liver. And it's also, it's frequently involved in penetrating trauma as well. This is our most commonly injured organ when we're talking about blunt trauma, especially our solid organs. But non-operative management is still typically in a stable patient is the treatment strategy we're going to use for these people. So Sometimes, if there's isolated, like right subcostal penetrating wound, they still might be managed non-op if we can get a good evaluation with our imaging of those patients. But all of these are going to get a CT scan if they're stable. If not, they're going to the OR. Like I just said, we have newer procedures we can use. I don't know how many times they've been around, as long as I can remember. But we do have our like angiography and embolization we can use. Typically, it's done by our interventional radiology teams. All right. What's the most common, or what's the most frequently solid organ injury in blunt trauma? It's going to be liver. We won't beat that. And then you guys don't need to know the grading criteria, what's in those for those, but you do need to remember like our higher grade injuries, like our 4 and 5s and 6s, are usually considered higher grade. And then we have our lower grade injuries, but asymptomatic patients who have a high-grade liver laceration will typically be managed with repeat imaging and admission to the hospital. And then we just monitor for continued bleeding. Now, if their vitals are staying stable, their blood work is stable, like their H&H is stable, a lot of times we'll just monitor them with serial exams and imaging. And typically, we do want to watch out because some of those higher grade ones can develop a pseudoaneurysm, which is the most common complication we see with that. And we basically document healing before we discharge them from the hospital. After discharge, if we're recommending routine imaging after discharge, we typically do it 4 to 8 weeks after the injury. Any high grade injuries, we have to re-image them at 3 months prior to return to any contact sports. So these are, these are going to be any of your like football players or anybody who's tackling each other, soccer. We're going to want to consider doing repeat imaging on them as well before we clear them for return to sports. All right. So the second most commonly injured solid organ is going to be our spleen. It does have some protection from our ribs, so it's it's not as common as the liver, but it is still pretty common. It may account for like 75% of the injuries that we see from blunt trauma in patients. So we do, we always consider our liver and spleen, and typically any mechanism that causes any sort of trauma to that area, we have to worry about. And we used to remove everybody's spleen, but now we realize that's probably not the best course of treatment. We actually need the spleen. Still haven't found the need for the appendix, but the spleen is a very important organ. So we don't like to remove them like we used to. Now, if we have a splenic laceration and that patient is stable, typically we're going to do the same sort of evaluation like we do with the liver. Stable patients are going to get CT scans, and then we're just going to evaluate for how bad that laceration is, and we have grading scales for that too. I don't know, I think we have them on the slide if I remember right, but we have different grading scales we use for splenic lacerations as well, and we manage them similar to our liver lacerations or liver injuries that we have. Even stable patients with a stab wound that we suspect splenic injury, typically if they're stable, we're just going to manage them the same that we do with everybody else. That's going to be CT scanning, serial exams, and imaging. If we're going to open the abdomen for anything else, though, we will obviously take care, we will fix that splenic injury if we find it. So isolated spleen injuries, we don't typically do an exploratory laparotomy on them. We do imaging in those stable patients. So here's our tricky ones, our duodenal and pancreatic injuries. So like I said, anybody with that seatbelt sign, we need to consider this in our differential. And like I said, our initial CT may not give us an indication, but typically these patients are going to have a direct blow to that area. So for like board questions, this is going to be like, your bicycle handlebar, the epigastrium, your skier, your some sort of, they hit right in the epigastrium, and that's typically when you need to consider this in your evaluation, that they have some sort of pancreatic or duodenal injury. And like I said earlier, they may have frank peritonitis, but typically they don't. And it's typically very vague pain that they have. They'll have back, flank pain, which is another important reason we evaluate that spine when we have a suspicion for these injuries or a high index of suspicion. But unfortunately, our physical exam may not be as helpful to rule in or out these injuries. All right, so you got a 17-year-old blunt abdominal injury, motorcycle collision. He's got free air and fluid in the right perirenal space on an abdominal x-ray, rigid and distended abdomen. What structure do we think is most likely injured? Yeah, duodenum. So any of those injuries in that area, whether it's blunt versus penetrating, we need to consider those retroperitoneal injuries. So like I said earlier, there's no specific lab that can rule in or rule out this injury. However, it should raise our index of suspicion, like if you have a patient, they say took some sort of injury to that epigastric or abdominal area, and you're considering that they might have a duodenal pancreatic injury, you then want to get an amylase on them, and it'll help heighten your suspicion if it's elevated. If it's normal, you still can't rule it out, but if it's elevated, you need to think, well, maybe there is something going on. And then you need to look at your CT imaging a little bit more closely if they didn't call anything on there. Because when we order all these imaging, like if we're not telling the radiologist where we think the injury is, sometimes those subtle findings may be missed on there, or we may even have to call the radiologist back and they get really mad at you. But you call them back and say, hey, we're worried about this. Can you take a look at this area again for us? And so they'll do a second look at it. And usually when you call them, they realize that like you're seeing something on there. And sometimes it may be just a normal variant in a patient, and they'll explain that to you, and you're like, oh, okay, cool, thanks. And that helps reassure you, but sometimes they'll have missed it, and they'll say, oh yeah, I do see something in there. They won't ever say they missed it, though. They'll give you some run around and say, yeah, I think I see something, and they change their report on you, and you're like, what the? And then typically, we're not getting plain abdominal films. If that's all you have, then certainly that's reasonable. Like I said, like your roll twos may have an ultrasound. They do have x-ray in them currently, but it's just plain films and there's no radiologist to read them. That's why it's important you guys are proficient at reading radiography. And then obviously our primary diagnostic modality is going to be our CT with contrast. We will add that enteric contrast if we need to evaluate the duodenum and look at that C loop. And then the common findings we see aren't going to say that there's some sort of perforation or bleed or injury to any of those structures. It's typically going to be subtle indicators like I see a little bit of contrast extravasation in that area. There might be some air, but typically the most common one we see is like fat stranding, which is very non-specific, but with the right mechanism and history, that's when we need to consider that they might have one of these hollow viscous injuries and they may need further evaluation or an exploratory lab product. All right, so here's your skiing patient. So ski pull of the mid-abdomen, present with severe pain, you got ecchymosis, rebound tenderness. You suspect they might have pancreatic injury, blood pressure, is that blood pressure look stable? Yeah, and the heart rate's, I would say stable, however, it's starting to tick up. So a young patient, probably, we didn't give an age, but most patients shouldn't have a heart rate at 99, so something's going on, right? So what is our best diagnostic study for this one? CT. Good. What if we said, what is the initial? What do you think, ultrasound? Yeah, like fast exam would be our initial. All right, so pelvic fractures. Like we talked about before, you lose a ton of blood. This says 4 liters, some says 3 liters, some says more. The bottom line is it's a lot of blood. It's going to be over half your body's supply of blood. So, and it can hide in that retroperitoneum. So that's why it's important we always check that pelvis in our trauma patients for stability. And typically, if they have a pelvic fracture, there's going to be concomitant injuries, and that can sometimes distract us from what's going on, because we might, let's say they're T-boned, they have a tension pneumothorax, they've got, an upper extremity fracture and a lower extremity fracture, which kind of throws you off just because of the amount of pain. So that's what we call those distracting injuries. And sometimes if we're not doing our thorough evaluation the same way every time, our A, B, C, D, E, all of our secondary, we're going to miss these if we're not paying close attention. So that's why we need to make sure we check that pelvis for stability. And then here's our technique. So we kind of talked about it. We have our prefabricated splints or pelvic binders typically at the bedside. If we don't have those, we can use a sheet, which works just as well, and we have to tie that sheet on there. And then we do like to wrap the legs together just to induce that internal rotation to help maybe, tamp out some of that bleeding that might be in there. And then once again, we got to do a good rectal and genital inspection. So if we got any blood at the meatus, if we got like a scrotal hematoma, high-reading prostate, or you get that gross blood on your rectal exam during your primary survey, we need to think about some sort of urethral or bladder injury in these patients, and we might want to do some further imaging before we put a Foley catheter in that. That's going to be our retrograde urethra. All right. So obviously, unstable patients, we need to get a FAST exam. That's why we do the FAST and the bladder in those two different views, just so we can further evaluate it. If it's negative, the pelvis can still be the source of the bleeding. We historically thought that it was arterial, some sort of arterial laceration or disruption from one of those fracture fragments. We think actually it's probably like venous oozing or venous bleeding that causes a lot of that blood loss that we see in these patients. It's hard to really study it, but a lot of times we'll find that they didn't have any arterial disruption or injury there, and they still lost multiple liters of blood just from venous bleeding within that pelvis. So obviously a CT is going to be important in a stable patient. In all unstable patients, they're going to go for some sort of X-fix or internal fixation and exploratory laparotomy. What do you guys see in those images there? I guess it says it on there. Yeah, they got open book fracture. All right, so for these, obviously we need to evaluate for any hemorrhage. Are they stable, unstable? Did we get a pelvic binder on there? Some sort of binder, whether it's a sheet. Has anybody ever heard of the pneumatic anti-shock garment in the mass trousers? Are you guys old enough to remember those? Yeah. So it used to be a thing that you basically put on these pants and blow them up. And the thought was that we're going to bring all of that blood supply back up to the important areas. Turns out it doesn't work as well as we thought. Kind of works, but we see a lot of other injuries when we do that, or a lot of other metabolic derangements, I should say, that actually can be worse for the patient. So the important thing is obviously getting in the operating room, but we need to get blood on board prior to that. If we have that urethral injury that we're worried about, we typically want to consult urology. We'll do that retrograde urethrogram, but if they need to go to the OR, we are going to need to get that fluid out of there. So they can do a urostomy tube or a suprapubic catheterization. You guys know what that is? Basically, right above your pelvis there, they're going to put catheter straight into there to drain that bladder. So, and you might even see some patients, especially if you're following them up after significant trauma in your even at your clinics when you're working there, you will see some patients I hate to poop on motorcycle riders again, but a lot of times you'll have those soldiers will crash. They'll have like polytrauma from a motorcycle injury, and they may show up for a follow-up and they actually still have like a suprapubic catheter in there, or they might have a catheter complication and you have to change it out. So those are, you know, it's always important to understand what we do for a lot of these injuries, even on the primary care side, not just the trauma side when we follow them up. All right, over Ebola. Has anybody ever seen one of these? You guys know what this is? So this is an interesting device that was designed. So you remember when we talked about thoracotomies, how we're opening up the chest, looking for any bleeding, we're cross-clamping that aorta so we can keep all that blood to those vital organs like the heart and the brain. So somebody designed this wonderful tool here that's meant to be placed in the femoral artery. So kind of like a central line, or what we call a cordis goes in there, but that goes in the vein. This goes in the artery in that same area. And the thought is, if we can insert it and inflate a balloon, then we can preserve or avoid a resuscitative thoracotomy. And it's been used in Afghanistan on at least 3 different occasions where they did it in a tactical environment or in a helicopter to help prolong that patient's survival so they could make it to a trauma center or an FST. So it has been shown some benefit. However, we have done studies, and the longer that balloon is up, like typically more than 30 minutes, you're going to have significant reperfusion injuries and metabolic derangements that end up killing the patient. So we use this, we don't really use it. It is in the TC3 guidelines still for trauma. However, if you are placing this, you need to know that you have a surgeon that you're taking this person back to, and you need to think about the balloon test. But it's a nice tool or technique that's out there. Very great thought behind it and idea. However, you know, the complications we've seen with it are pretty drastic, which has made it less common, but it is still used. It is important to understand it. And as you can see in the little photo there, we place it in a couple different zones. So we place it in like zone 1 and zone 3. So if you have some sort of pelvic injury or bleed, and you need to stop that source of bleeding until they can get to an operating room, then you can place it down there in your zone 3, and then you have your zone 1, which is like your aorta, you know, which is your like proximal aorta, which is where you typically cross clamp it with a resuscitative thoracotomy. So we also can place it higher as well. All right, you got a patient struck by a vehicle, tachycardic, hypotensive. You don't see any signs of external hemorrhage, pelvis unstable. You got a pelvic fracture, internal hemorrhage. What's the best initial treatment that should be performed for this injury? And we bravo. Put that pelvic factor on there. Good. All right, so some of our post-op complications that we commonly see for an XLAP, it is a very large procedure. What we found is that if we close that up immediately after the surgery, we run a risk of what we call abdominal compartment syndrome. And this can happen after long abdominal cases like significant manipulation of those internal organs, or if they required a massive transfusion. Most of the time, we don't close these patients with like primary intention right afterwards. We typically place them on a wound vac to drain up all of that fluid until we can close it later. So it's important when we're evaluating a patient, anybody that had a closed abdominal wound or closed wound after surgery, and they start to present with, you know, increasing abdominal pain. It can also start affecting your airway pressures. If you think about all the pressure that's in the belly, it's going to start pressing upward on that diaphragm. And we can also compress some of those great vessels in that area as well, so we can get decreased cardiac output. You're obviously going to have your increased systemic vascular resistance. So we need to consider this in any patient that has their abdomen closed if they present afterwards, or when you're rounding on them after surgery. We need to think about abdominal compartment syndrome. And typically the treatment is just open that back up. So decompressive laparotomy, they'll open the incision back up and relieve that pressure in there. All right, so post-op care, we tend to use a lot of different drains on these patients. There's even more fancier ones now, but one of the more common ones, we have our Jackson Pratt, which is a closed system suction drain, which is that little grenade-shaped one at the top. And then we have like our, anybody ever used a Penrose drain? It almost looks like a latex tourniquet, except it's an enclosed tube. So that's another drain we used, but it's not under suction, it's just open to drain that fluid out, or that serous fluid or whatever we're trying to heal. So those are two common ones we use. We now use larger wound vacs that can be plugged in or battery operated, that are a lot fancier. And we do send patients home with those a lot of times too. We send them home with home health nurses, and people actually can go home or check on them daily to manage these patients so they don't drain resources at our hospitals. All right, so here's our scenario. You got a 24-year-old male using MVC, highway speeds, restrained, extrication with like 5 minutes at the scene. He's hemodynamically stable, approximately 15 minutes to your goer. And he's complaining of lower abdominal pain. So what do we see initially right there with the picture? Yeah, seatbelt sign, so that's not good. How are his vitals looking though? Yeah, his vitals look good. So what are we doing for this patient on our primary survey? Yeah, we're definitely doing a fast exam on this patient. So let's say the fast is positive. What are we going to do? Yeah, CT. Why? He's stable, right? Okay, well now what if it was, his pulse was 140 and blood pressure was like, 85 over 40? Yeah, he's going to go to the OR for next lap. Good. All right, got another one. What about 18-year-old periumbilical gunshot wound, 15 minutes ago? I assume he's complaining of abdominal pain. Primary exam reveals 1 GSW, 2 centimeters from the umbilicus, superiorly, it's hemostatic. How are his vitals? Yeah, they don't look good, right? So it looks like you got diminished distal pulses and no other injuries. You got IV access. You got to get that life-saving tetanus. Where are we taking this patient? Yeah, he's going to go to the OR for exploration. He's definitely bleeding from somewhere, and he's got penetrating trauma of the belly. He needs to go to the OR. All right. So we talked about blunt trauma. May or may not need surgery. Typically, they're gonna, if they're stable, they're gonna get further evaluation. Most common blunt injuries are gonna be liver and spleen for your solid organ injuries. And then, if the FAST is negative, we'll typically observe them, it's stable. If it's positive, then surgery if they're unstable. If not, then we're typically gonna get a CT. And either observe them if it's negative or if it's positive. We may do serial exams, we may still go to surgery, we may observe them. It's all patient dependent. But for penetrating, most of them are going to go to the OR. So we don't want to delay any sort of surgery for our further imaging or our FAST exams. And we typically don't want to blindly probe those wounds as well. So it's very common, it may sound like that's a no-brainer to you guys, but a lot of times in the emergent setting, we want to explore most wounds that we evaluate. But when we're looking at the abdomen, that's usually something we don't blindly probe or explore. Typically extremity injuries we do, sometimes with chest injuries we do as well, because we want to identify the depth of that injury. Do I have any sort of foreign body in there? What am I evaluating? What am I basically looking at? How deep is this? What sort of structures are under it? Injuries? So a lot of times we do probe those injuries, but not for the penetrating abdomen. All right. What questions you guys have?
As far as not blindly probing the penetrating abdominal wounds, if it's a knife wound or that doesn't include making sure that
No, that's not blindly probing. And a lot of times blindly probing, we'll take either a finger or a con-tip applicator and we'll kind of place it in the wound to check the extent and the depth of that wound. So that's typically what like a blind probe would be for it, and we typically don't like to do that for the abdomen. Basically, we don't want to insert any sort of other material, bacteria, anything that might be on the patient's body or your glove into that patient. Yep. What other questions? Yes. The what? Yes. 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 How do you confirm? Great question. We don't know. You can, so we've actually done studies for it. I was actually even did one. We tried to do a bubble study with ultrasound. Basically, we throw some, basically shake up like saline, place it in that bubble, and those air bubbles, we might be able to see them as we're actually injecting it, and we can see it on the ultrasound. We've tried to like pioneer different techniques to evaluate this. They do have like radio opaque material, but not for ultrasound. So, I mean, you can get an X-ray, you know, if you have that capability at that point. And this is obviously something like an urgent procedure or emergent procedure that we have to do. So a lot of times we don't have X-ray capability and things like that. Now, it is something that can be placed in a roll too if you have a short evac time to a surgeon. And you might have an X-ray, but you really don't want to delay care for the X-ray, which is why you're really confirming that you're in that artery, the femoral artery, and you're placing it. So that's why I said it's not as commonly used, but it is something out there, and it can be used in the right setting. All right, take a 10-minute break.